Hello, everyone. At the outset, I would want to thank Dr. Lee and the organizing team of LT Updates for having me here. And thanks, Dr. Hong, for actually setting a very good stage for me. And I would start from the statement which he made. Uh, Patients who survive beyond 1 year, they usually end up surviving well. And that is what decides the long term outcome in patients who are undergoing liver transplant. Greetings from my hospital and Liver Transplant Society of India. So retransplant is not something which is new. And if I have to talk about evolution of retransplant, the first seminal paper from Professor Starzl in 1982 mentioned about the first 27 cases of retransplant. At that time, the reason for doing retransplant is to achieve survival of the patients who were undergoing transplants and having graft failure for various reasons. But at that time, only 22% patient could cross 6 months. From there to now, the percentage of liver transplant is kind of going down. And if you look at the data from UNOS, almost 7 to 10% of the patients get relisted for liver transplant, and 5 to 6% end up getting retransplanted depending on what stage of graft failure, acute after the transplant or later, the etiology differs. Mostly early stage is because of vascular or graft dysfunction or non-function. Later is either chronic rejection, recurrence of disease, or commonly seen in LDLT settings is biliary complications. So this is how a graph plotted by European Liver Transplant Registry at various stages after the transplant, what are the various indications. Now, as Professor Hong mentioned, the indications are also important to decide how the outcome is going to be, and that is the reason I'm trying to mention and look at this slide. Various period after the transplant, there are various indications, and depending on for what indication you're doing the transplant decides the long-term survival. Now, looking at the Eastern perspective, a single center perspective, Asan published their data a couple of years back, and they had 3.1% retransplant rate with overall 1 year survival of 63%, with etiologies mainly as addressed in the previous slide. One of the large volume Indian center, they have done more than 4,500 transplants, and their retransplant rate is close to 1%. They've also found out that the early transplants had a higher mortality compared to late transplants. And this is something which is important to understand, that there are various reasons why patients have high mortality in early period. I'll come to those factors in a little bit. At our center, we have done more than 1,300 transplants. Our retransplants are 0.76%, although we have advised transplants to more patients, but we ended up doing 10 retransplants over this period with almost 70% 5-year survival. Now, coming to my main set of talk, and now you'll see some studies which Dr. Hong has already referred to. I'm going to be addressing them with a different perspective, which is like how to achieve a long-term prognosis and what are the predictive outcomes. To understand that, there are few things. I'll go one by one. One is, over the last few decades, how much the success of transplant has increased. The success of transplant has increased in terms of primary transplant, and such is the success which has increased for retransplant for obvious reasons. Second is the predictive factors, which are donor or recipient factors, then the technical factors, and on the basis of that, there are a lot of predictive scores, some of which already addressed in the previous talk. And then these patients also require a good long-term care strategy, and then what all practices or what risk mitigation we can do in these patients to achieve that kind of survival. Again, as if you look at these recent publications, the left one is from Canada and right one from Japan. So almost 60% 5-year survival for retransplant, but for patients requiring retransplants, the survival is lesser. The similar data from European registry, patients getting early transplant, 5-year survival is close to early transplant 45% and late transplant is 50%. But then important thing is, this is data which has been collected over 50 years. So it does not take into account the time changes which has happened. And secondly, the definition of early and late is also divided in the literature. A lot of studies have mentioned 1 month as cutoff, some studies have mentioned 6 months, and some have 1 year. So depending on those, there are various data which is available. So it is very difficult to actually compare the early and late in long terms. So now going to era-wise survival. This is a good paper from Australian New Zealand registry, which looked at their retransplant survivals before 2000 and after 2000. And what they found out that there was a significant improvement in their primary as well as retransplant survival. Now their retransplant survival 5 year is close to 75%, and which is coming closer to their primary transplant survival. And there are multiple reasons for that. Obviously, improvement in the surgical techniques, improvement in ICU care, decrease in the graft failures after the transplant as well, with better DAs available, better understanding of immunology. So all that is contributing. But this is something which we have to understand will help in getting a long-term survival in retransplant patients. So this is another data from living donor setup from Professor Tanaka. So they looked at transplants done within 6 months and after 6 months. And what they found out that re-LDLT can give a survival of 77.5% long term. So important thing in the LDLT scenario is timing. Before the patient becomes too sick, if you do the transplant and that time the transplant well, you can get those kind of results. So most of the data which looked at the overall transplant, particularly disease donor transplants, by the time the patient gets an organ, the sickness goes up, and that is what is shown in the predictive factors. Now, this meta-analysis is already discussed in the previous talk, but I'll just highlight a few important things. So age definitely is a risk factor. Higher the age, higher the risk of mortality, which is there either in primary or retransplant. You can't do anything about it. Gender difference, females tend to do better after transplant, after retransplant, again, you can't do. So what is important? Renal dysfunction. If someone whose creatinine has been going up, they tend to do comparatively less in terms of survival, both in terms of primary and retransplant. And hepatic function. We have seen more dysfunctional liver when you do transplants. Sicker the patient, they tend to do comparatively worse in terms of transplant. Now, the window of doing a transplant is important. If someone has a PNF, and if that patient has to wait for a long time, obviously that patient is going to be sick and the risk would be inferior. So this paper says if you have to do a transplant, do it early. So that is the reason for patients getting transplant within 7 days of primary transplant does well. But patients who get the transplant after 8 days, their outcome is inferior. This paper also talks about the overall duration of graft failure to the transplant duration. If it starts to go beyond 30 days, again, the survival improves, suggesting that this patient's situation is otherwise stable, would be able to tolerate the transplant. So those are important indicators we have to look at while we are considering a recipient for transplant. Now, donor factors. If you are taking an older donor, fatty liver or borderline donor, obviously the impact on the outcome would be significant. And this is also seen in the Japanese multi-center survey as well, where living donor transplant, although not statistically significant, shown to be giving better results, long-term results, compared to disease donor retransplant. In this study, they found out that pediatric retransplant data, the outcome is much better than adult, which might be related to the factors that the center which contributed to these cases were high volume pediatric centers. Their as it is results were very high. So when this analyzed this data, patients who were in the hospital before the transplant, who were either on mechanical ventilation or the etiology wise, the transplant done for early allograft dysfunction or small for size, did poorly after the retransplant. And similarly, in pediatric age group, inpatient status and early retransplant and patients with allograft dysfunction did poorly after the retransplant. And now this brings an important thing. Patients with small for size or early allograft dysfunction, Most of the time, the trials of medical therapy goes on, and these patients become sick, septic. They go through various septic episodes before the tree transplant happens, and that is the reason their outcome is inferior. And most common reason of mortality after retransplant is septic complication, and out of that, 50% is fungal infections. So similar thing shown by this American Center on Pediatric Retransplant. If a pediatric patient had a primary non-function, if the transplant done early, the outcomes are as good as primary. If it is done after 8 days, the outcomes become inferior. So this is data which we collected from almost 38 centers across India of re-LDLT, primary living donor liver transplant, followed by re-living donor liver transplant. So 9 centers contributed the data. A total of 97 patients were analyzed, and 77% of these patients were adult. This data was presented in last ILTS as well. And what we looked at is patient transplanted within 1 year. They did inferiorly compared to the patient transplanted after 1 year. So patient transplanted after 1 year, their 5-year survival was 83% compared to patient transplanted within 1 year, where the survival was 49%. Again, that brings out an important thing. These are the same etiologies where the delay happens because of the septic reasons. So now, with all these factors, there were a lot of predictive scores that came out over last 2 decades, looking at which patient to select for retransplant and what are the optimum conditions in which the transplant should be used. So various mathematical models that were given, taking into account all these donor recipient factors as well as surgical factors like amount of blood transfusions, and then scorings were done. But pretty much these scores are more of mathematical advantage than actually giving you any benefit in terms of prolonging the overall life. So the recent ones which were studies, one of them is BAR score, which was actually designed for primary transplant, was assessed for retransplant, and they looked at the factors like MELD score, donor age, recipient age, ischemia time, retransplantation indication, and life support. So basically, they divided the score from 0 to 27. Anyone getting a score more than 18, the survival goes down to 50%, which, as addressed in the previous talk, most of the centers, the consensus is 50% should be a 5-year survival to consider someone for a retransplant. So anyone with a score of 18. So this is basically, the score gives an advantage of identifying a cutoff of 50% 5-year survival. But more than that, what this score did was to predict septic complications, which is very important in retransplant scenario, because if you can predict that these patients can get septic complications, you can start treating them, you can upgrade the antibiotics and actually prolong life. So this was one of the advantage of this score. Then there was a soft score again designed for primary transplant, which was reconsidered for retransplant and looked at various factors. They also looked at the factors which were particularly recipient factors like performance status, the nutritional status, the bilirubin. Some of these factors in these days we can talk about prehabilitation if there is an option which is available in terms of late transplant. So if we look at this score, this is able to give us a low risk category, medium risk and high risk category. In low risk category, you can use an older graft to get even good results. So this is how this score can be utilized to select the donor in these situations. This is a French National Registry score. They also looked at various recipient and the potential donor parameters, and they came out with us the groups. If there is a low risk recipient and a low risk donor, what would be the success? And similarly, they divided these into various groups. And that is how you can decide that what kind of recipient and what kind of donor you take, and you can actually decide on whether to go for this transplant or not. This is another score which was mentioned again. So this is an important thing is they have an app. This is from Minnesota. They looked at the SRTR data and used a machine learning model to develop a score which can be utilized to counsel a prospective liver transplant candidate. but also it can help in guiding the donor selection. So if it's a little high risk recipient and you take a low risk donor, again, these are the things which can help in getting a better outcome. And as reiterated in this paper, patients who cross 1 year survival, they actually do as well as any other transplant patient. So our idea of achieving long term is to achieve a good short term survival. So this is on the basis of ELTR data. They looked at a few factors, and then they compared this model with UNOS data as well as all previous scores. And they found to be, after externally validating, this score found to be the most robust score to look at these variables. Now, with all this, we have to decide a benchmark of retransplant. If there is a benchmark for primary transplant, for HCC, there has to be a benchmark for retransplant. What kind of patient is the benchmark we are aiming for? So the ideal benchmark, as mentioned in this paper, is a MELD of less than 25, no portal vein thrombus, no mechanical ventilation, and if you're giving a young DBD donor a full-size graft, these patients will have 90% 1-year survival. So all future comparisons should be to this benchmark group to do any further studies. Now, these are donor and recipient factors. There are technical factors which are, again, very, very important in retransplant settings, because when you're doing a retransplant, it is technically much more complex. The vessels have been used up. When you're doing late, a lot of additions are there. And these transplants are comparatively more difficult. So the center volume impact is very significant, because a high volume center can bring down the ischemia time, can bring down the blood transfusions. There has been a data where if the blood transfusion goes beyond 30 units, the chances of mortality post-transplant is very, very high. So we have to look at all this and try to consolidate these retransplant in high volume center to get good results. Now, coming to a final round of clinical decision framework. So we have to select the patient on the basis of these criteria. We have to centralize, as I mentioned, the center selection is important. And then another most important thing is the long-term care of these patients. These patients tend to have more, because they have undergone a retransplant. The first year of aggressive follow-up is important. A protocolized approach should be done to make sure these patients do not develop any kind of complications. Now, coming to the last part of my talk, the risk modification strategies. What can we do to prolong or what can we do to mitigate the risk? Actually, if we look at the risk, we can mitigate either by modifying recipient factors or donor factors or procedural elements. Now, if we look at all this, the truth is there is little we can do. We cannot actually convert an intubated patient to an extubated patient. You have to accept the patient in that ways. You cannot modify the age, cannot modify the gender. And obviously, you can't modify the MELD. But then what you can do is you can look at the graft quality. You can look at the timing of transplant. You can minimize the warm ischemia time. You can minimize the blood loss. And based on the scores, if someone has a high chance of having septic complication, you can upgrade the antibiotics. So make sure these patients do not get septic in. Now, looking at the evolving practices, now these days with the machine perfusion, we can optimize the graft and use that graft. The other options are, again, as I mentioned, surgical technique, rehabilitation, timing the transplant, which can ideally be done in living donor settings, and infection prevention. And then further models on the basis of that to look at how we can make sure that we can achieve a long-term survival after that. So this is one of the abstract that was presented in recent ATC meeting, which showed machine perfusion improved a 75 to 80% better patient and graft survival in retransplant settings by optimizing the graft quality. And this is one paper I wanted to highlight, which looked at long-term outcomes in terms of timely living donor liver transplant with better surgical technique. You can achieve close to 100% 5-year survival in these settings. So important thing is timing of the transplant, minimizing ischemia time, and making sure you use the best possible graft which is available. So to summarize everything, to navigate the complexities, the important thing, the quality of the graft, timing, patient selection, and the multidisciplinary expertise is required to make sure we get a success in liver transplant and retransplant. It is important to know when and whom this complex intervention offers the best chance of meaningful recovery. Thank you.